Hi, my name is Jordan,
And my name is Marlo.
and we're going to be presenting X-linked dominant hypophatemic rickets, XLH. So today we're going to be going over the introduction, the etiology, genetic characteristics, forms of rickets, normal phenotype versus abnormal phenotype, genetic mutations, diagnosis, symptoms, gene therapies and treatments, and then our references. I'm going to pass it over to Marlo to get us started.
Okay, so to begin, ricket is a disorder in children caused by a diet deficient in phosphate, calcium, and vitamin D. It leads to softening and weakening of the bones. X-linked hypophosphatemia, or XLH, is a form of rickets, and it is caused by the mutation of gene F2, F23 on the X chromosome. This gene normally makes a protein called fibroblast 23, which is produced in bone cells. This protein is necessary in regulating the phosphate levels within the body. So as a, reminder, I'm sure you all know what the phosphate mineral is, but let me just remind you, phosphate is a molecule that is made up of phosphorus and oxygen. It is required for healthy bones, muscles, and teeth. So XLH occurs when the levels of the mineral phosphorus are low in the blood, and too much phosphorus is excreted in the urine. This is known as phosphate wasting. Okay. So phosphate wasting is or can be caused by hypophosphatemia, which is low phosphorus level in the blood. It impairs mobility, including bone fractures, hearing loss, ligament and bone pains, and increased risk of infections such as spontaneous dental abscesses. So the significance of this order, it is the most common form of rickets that runs in families, with an incident about 1 in 20,000 newborns. Many cases are found in Latin America, specifically in the southern region of Brazil. However, many more occur in Japan, Denmark, and Norway. Now, going back to your question, Dr. Edwards, when you asked last time, the geographical location, where could, the prevalence be? And I thought that the prevalence would be more significant in lower lighted or shorter days, the geographical areas, or in geographical areas like Middle Eastern countries where they're all covered up. But no, I found that in my research that it's mainly in America, but many more in Japan, Denmark, and Norway. And I'm assuming that this is the case because of shorter supply of medication or poor nutrition. Affected children experience slow growth and are shorter than their peers. These children develop rickets or bony abnormalities that result from the low phosphate levels. The most, the most noticeable of these bony abnormalities is severe bowing of the knees. If untreated, the condition worsens in time. So we're looking at these three types of phosphatemia. The first type is the bowing at the knee level. The second one is the curving at the knee level. And the third one is what they call knock-kneededness, when the knees come together and knock. So the deformities manifest in late infancy. Basically, when the baby is able to walk, that's when you will start seeing this bowing factor going on. It is most common in children, but unlike dietary rickets, it may affect individuals at any age. Prolonged vitamin D deficiency leads to osteomalacia in adults. This is when the bones bend and become soft and weak. Now, looking at my friend over here, this is where I brought the chair. I don't know if this moves or not, but let's just say that this is an adult and he is experiencing this type of disorder, what's going to happen, he's going to get shorter as his bones start to bow, mainly at the knees. And it could allow him to walk, but a lot of times with osteomalacia, they wind up in wheelchairs. So the etiology of this disorder is XLH is caused by a defect in a gene called FEX, gene on the X chromosome. This gene is responsible for regulating phosphate in the body. The genetic change prevents the kidneys from processing phosphorus correctly. The change in the gene reduces the suppression of a hormone, which is fibroblast growth factor 23. This regulates how the kidney filters phosphorus from the blood and excess in the urine. Basically, if you do not have phosphorus in your bloodstream or enough phosphorus in your bloodstream, then it does start to affect the health of the bones.
Thank you, Marlo. I'm going to be talking about the genetic characteristics. So it is an X-linked dominant genetic inheritance, which means it only needs one copy of the gene to be presented as a disease. If the mom carries the gene, she has a 50% chance of passing it on to her son or her daughter. If the dad carries the gene, he can only pass it on to his daughters. They also have other forms, which is X-linked recessive, autosomal dominant, or autosomal recessive. Autosomal just means it is not found on the sex chromosome. Now, there are 3 forms of rickets. There's calcipenic, phosphatenic, and inhibited mineralization rickets. Calcipenic is when there's an inadequate intake of calcium through dietary or poor calcium absorption, which you can see with celiac disease or cystic fibrosis, or also a genetic defect when it comes to the vitamin D metabolism and can't switch over to the active form, or in organ resistance. With phosphatenic, which is the one we're talking about, it is when there is a chronic low serum phosphate levels, either from impaired intestinal absorption or increased renal loss, which is what we're going to really be focusing on, is the increased renal loss. And the last one is inhibited mineralization rickets, which is a defect in the growth plate in the presence of normal serum phosphate levels and calcium levels. So the genetic mutation, XLH, is caused by a genetic mutation of the FEX gene, which is found on the X chromosome. It can manifest itself in 2 ways, which is FGF23 dependent and FGF23 independent. FGF23 dependent is characterized by abnormality in phosphatonin, which is FGF23. We're going to keep it at that. And it's used to regulate phosphate homeostasis. And FGF23 independent is not phosphatonin dependent, which is FGF23 dependent. And it's actually normal FGF23 levels in this state. And it's due to renal tubules and problems with the phosphate transport defects. So I'm using the cursor for you guys online. Okay, so right here. Let's see, people online can see. So right here, you're going to see the FEX gene this is the normal functioning. The FEX gene is supposed to cleave to FGF23 when the phosphate serum levels are too high, which inactivates the FGF23. FGF23 is used to regulate the phosphate levels to go lower. It allows the kidneys, the kidneys aren't allowed to reabsorb the phosphate, which causes a decrease in phosphate levels. So the more FGF23 is in the blood, the more the phosphate is unable to be absorbed, basically. So right here is XLH. I'm going to circle for you guys online to see. All right, here, this is the one that we're going to be focusing on. It's abnormal cleavage of FGF23. As I had said, this is autosomal dominant hypophosphatemic rickets, and this is tumor-induced osteomalacia, and all of these lead to hypophosphatemia. But as you can see right here, you see these sodium phosphate transporters. These are responsible for the transport between the kidneys and the gut, which is getting the phosphate from the kidneys to the gut for absorption. So without enough transporters, there's a backup of phosphate leading to excess excreted into the urine, which is phosphate wasting. And then right here, you see 1-alpha hydroxylase. This enzyme is actually responsible for switching vitamin D to its active form, and vitamin D is responsible for allowing phosphate to be absorbed in the gut. So when there's a lower amount of the enzyme to convert it to the active form, you're going to see a decrease of reabsorption of phosphate in the body, leading to hypophosphatemia inevitably. So now we're going to go over your normal versus abnormal phenotype. Right here is a 2-year-old female. She has distal tibial metaphyseal flaring, which is the bowing of the knees right here, as Marlo talked about earlier. And right here, you're going to see a difference in the mineralization because phosphate is what allows the bone to mineralize. And right here, if there's a deficit in phosphate, there's poor mineralization, where you see is a lot of pores going on, which causes the bones to be very weak. And diagnosis, we have serum alkaline phosphatase. That's common. Like you said, there's going to be a low serum phosphate level. So if they're going to do your blood work, if there's a low serum phosphate level, obviously that's a sign that you may have rickets. They also do the serum 25 hydroxy vitamin D level. Again, that leads to absorption of phosphate in the gut. That's another sign. And measuring your urine phosphate, again, with XLH, you're going to be excreting phosphate in your urine. So high levels of phosphate in your urine indicates XLH, and then they're going to measure your blood urea nitrogen and creatine levels to screen for your renal status, which is your kidney status and how they're functioning. I'm going to pass it back over to Marlo for signs and symptoms.
Thank you, Jordan, for that analysis. The signs and symptoms, first starting with children, rickets, dental abscesses, fractures, bone pain, delayed growth in adults, short stature, depression, osteoarthritis, granulovenous, hearing loss, impaired immunity, bone pain, and of course, osteomalacia. So the previous treatment and therapies for this disorder was human growth hormone, calcitrol, phosphate, Caltrio. This treatment and therapy are considered the last, it was more invasive, so this is considered the last step. And it's mainly because of the unwanted effects such as secondary hyperparathyroidism, kidney stones, and cardiovascular abnormalities. So the more desired treatment and therapies include increased levels of phosphate through intake of proteins, dairy, and nuts and seeds to allow the body to develop and function more normally, prevent dental abscesses by regular oral hygiene with flossing, brushing, and general dental care, improve pain and lower extremity bowing with oral phosphate and active vitamin D supplements, and if all of those have not worked, surgery, which may lower limb bowing and or torsion.
These are our sources.